I was the previous president of INAI and the advisory board chair at this time. I have more than 30 years of clinical experience in various areas, and I was a certified mental health nurse for almost 10 years. Right now, I serve as a nurse manager, clinical nurse manager for post-acute care in VA, one of the VA medical centers.
I also am an adjunct faculty at Wills University, Pennsylvania, teaching statistics in nursing. I'm also an ongoing researcher with NINA actively, and other research outside of NINA also. And I'm also a mentor for School of Medicine, Nursing, and Public Health in terms of research projects, both evidence-based and research and basic research. And I'm happy to be part of this task force in terms of mental health, improving the mental health of our youth and young adults.
Good morning all, I'm Ken Stachel. I'm from INAI, from Illinois. When it comes to mental health, right after my nursing graduation from BSN, was teaching in mental health department for almost 3 years. And I came across various mental health issues from patients and also from staffs, also from our students too. So being a nurse for last 17 years, we all know mental breakdown is not simple, but we have to send a strong message saying that it's same like other diseases. It's not a stigma. We have to break that stigma in. So as a nurse, we have to work towards it, and it's great honor to be a part of this panel discussion.
Good morning, everyone. My name is Nimi Tong. I serve as a nurse manager in Cook County Hospital. In addition, I also support the supporting lead for the patient care support nurses, and I also take initiatives on fall projects in medical surgical division. In addition to that, in INA chapter in Chicago, I serve the fundraising chair role. In addition, this year, I have got a great opportunity to be more active in INI. Even though I was a member of the INI, I wasn't very active due to my personal, commitments. So this is a great opportunity this year for me to be part of the mental health initiatives when they started this year. I thought, okay, let me make use of this opportunity. We want to grow. Well, I have seen that my nieces and nephews or our own South Asian community is going through a lot of struggles with the mental wellness or mental health. So I thought this is an opportunity for me to serve the community, to understand better, to be a part of this task force.
So, this is to Dr. Lucas. Can you enlighten us as a member of the task force? Why is mental health first aid training, and how is it different from the tradition? What is mental health first aid training, and how is it different from the traditional first aid training?
Yeah, we all know the answer to what traditional first aid training is, right? You have a wound, you put a Band-Aid on it. If there's a physical emergency, there's a wound, you take care of it, you put a Band-Aid, yes. But if you have, what happens if you have a mental wound? So the physical wound is seeable, right? You can use your senses to make sure you can see it.
Director, leading a diverse group of 60 to 70 direct reports, doing shift work. What strategies can you suggest to promote mental health and prevent substance abuse in your teams?
Thank you for the question. As I said, being a nurse for the last 17 years and being a leader for the last 4 or 5 years, as a nurse, we all should focus on creating a culture where well-being activities are part of daily practice. Promoting mental health where everyone treated equally with dignity and respect. What it creates open communications. How open communication can create trust and relationship.
Our chapter has submitted a grant for the mental health initiatives. So we'll be starting in the high school, especially in Naperville area. We had a lot of kids committed suicide. So we are focusing on those areas first, since we are in the initial stage. I think Dr. Joseph will be able to speak more about it.
The grant was for a community grant, so we have to provide that community as to be the focus. That's the only difference. But we haven't approached any national grants so far. So this is our first step for a local grant, and if we get that, it's 25,000 for any type of these activities we can apply, and to that population.
Yeah, do keep the NINA informed so we can translate those research activities into our own chapters and communities.
Yes,
please.
There was a proposal actually to take a project like this as a community education program for NINA. We used to do community education we have done for stroke a few years ago. So it's similar like mental health. That was an idea that we have. I'm sure we'll do it. So it will take us a national project. So all the data that we collect, amount of people and amount of people we educated would be a big. You guys weren't there, right?
But it was an amazing presentation. Let me just hand over the certificates to them. Dr. Rani Kaban.
Sure.
Take care of the family member, children, cooking, everything. We are working and nobody understands what we go through. So that's the biggest challenge I see. It diminishes the quality of life for the especially care, because the person who is suffering, they don't know what's going on, right? So we are the ones suffering, that's why. And we consider this is like normal aging, we don't consider it's a person's life, and that delay in seeking the care, even dementia diagnosis. Even above that, it's very difficult to schedule the appointments, neurologists, as you work as nurse practitioners. It's too late when they come, right? And then we see affiliate stigma. I just want to show it's a caregiver stigma, associate stigma. It's like courtesy. We say it's like negative beliefs, feelings, behaviors experienced by the caregiver due to association with the stigmatized user, which is the patient. And literature we did we adapted the scale. This was initially developed by Dr. Mak and Chang in Chinese and English version, so I adapted these 22 items. They developed initially for intellectual disability and mental illness, so we adapted and changed dementia words and few words, and with the experts they review the scale, and we did the study. It has 4-point Likert scale, and high score indicates higher stigma. And this was globally adapted in various languages, various countries. And this was conceptually equivalent, so comprehensive, reliable tool. So that's the reason there is need to adapt, validate in this population, because it was not available in this American, those are living caregivers here. So into that as a being going in research, because everybody, if I'm giving someone, I have to give fact, reason why I'm using it, what is causing. Thank you.
Thank you so much. Please give her a round of applause.
Thank you for being here.
Psychiatric mental health nurse practitioner with over 17 years of experience, and she's working as a registered nurse. She had 17 years of experience in her clinical nurse practice across diverse healthcare settings. She currently serves as a forensic psychiatric health setting in the unit, providing evidence-based, compassionate care to the individuals with complex psychiatric and behavioral health needs. I welcome Dr. Meenu Shiv.
It's easy to take nurses, but the amount spent by an organization is tremendous. Just to recruit a med-surg nurse would be $12,000. If you are a specialty nurse like ICU, ER, it would take minimum of $125 just to train them and bring it out. So the root cause would just be bullying or something, but the impact is tremendous. So that begins to my search on evidence of literature on what we can do to curb such a situation. So that's when I came across cognitive rehearsal. So the name itself, cognitive and rehearsal, that has something to do with our brains and our cognition, and that's something you can you have to keep on rehearsing. So there were tons of articles on workplace bullying, and they have tons of articles have used cognitive rehearsal. This is a good evidence-based tool if you're using for a new graduate schools who have just come out. Training them on cognitive rehearsal is an excellent way. So these are a couple of studies. So what is exactly cognitive rehearsal? This was first given by Martha Griffin in 2004. She, along with Cynthia Clark, came out with a study. So they tried, she created pre-planned assertive responses.
And thank you all for being here. And so today's class is about artificial intelligence, foundations for nurses from basics to bedside. So our objectives today are gain foundational AI knowledge, advocate for safe implementation of AI, and engage confidently in interdisciplinary AI initiatives. So this is going to be a discussion mostly. So let's understand some of the basic terminologies in artificial intelligence. Their activities, whatever is going through, is very difficult for a person to program. So that's where the machine learning comes in. So machine learning also, it has the machines learn from the algorithm, data. These are all really important words. Okay, so the machine learning, that's where the machines come from. The machines define the rules for the program. So whether to give if it is a recommendation, or whether to predict what the stock price is, what the weather is for tomorrow. So all of those versions are defined by the machines. So the machines are defining the rule. But where does the rules come from? Where does the machine get the input? Okay. So there are the machines get the input from data. So whatever data is the foundation of all machine learning and artificial intelligence. So basically the data, the information comes from the data, whereas how does it define from the data? How does the machine define the rule? The trend of the data. So that is correct in one way, but how does it decide? So somebody said algorithm. So there are algorithms. Those are algorithm. What does algorithm mean? Okay. So algorithm is a steps to follow. So we all follow algorithms in the clinical area. So it's similar to that. But whereas in machine learning, all of these algorithms, all of the steps are, what's the difference? These are all program. What? Okay, it's a mathematical step. Okay, so that's the difference. So it's an algorithm, but these algorithms used in the machine learning is all mathematical steps. So all of these algorithms, so machines will use when the things are too complex, when the data is too complex for human to define humans provide the algorithm for the machines to learn from the data and define the rules automatically. We don't have any thought in the rules. The rules come from machines automatically. Okay, so that's the difference between machine learning and what is deep learning. So these are all the terms that you always hear, and the nurses usually don't know what it is, and usually the younger generation is more aware of some of these things, but most of the time there are so many misconceptions. Some people are really not avoiding the AI altogether. They think that it is something taboo, And whereas some other people embrace it altogether blindly, that is also dangerous. So we need to know what it is, then we will have enough knowledge to differentiate between what is artificial intelligence and how to use it. Okay.
And filled with water, and we shared a piece of mint stem, a sprig. So they collected their room. Surprisingly, after 3 months, when I visited, every window sill is with mint leaves. And as soon as I walked, they were so much bubbly and they had so much to talk about. Common subject. It's about the plant, how they, how it made them so happy. There is a reason for them to get up from the bed. And whenever the family visited, they even were talking about the plants, herbal medicine. I heard somebody was talking about fennel, she left, and yes, and somebody was talking about herbal medicine, all that. So they had so much to talk about, and they were looking at the YouTube and shared some more experience with their visitors. So they had a topic to talk. When I was listening to them, looking at their face, I saw happiness in them, a smile. So with a small plant, I made them smile. Another scenario, I work in the college as adjunct faculty, and one day I saw one nursing student. Here the nursing student, most of them have so much problems, not like fortunate like us. They came with shabby clothes, hair not combed, no makeup, not like us. If they don't have makeup, they have some problem. They come up with so much of makeup. So I understood they are facing some problem. So I took the student aside, and she shared, I couldn't believe, a horrible story. I couldn't digest it. So then I said, this is the only way I know. I am offering her a therapeutic intervention that is
really sick. How do you ask them to fill the form? They are at high risk as they walk in because they are really sick. How do you ask them to fill a form? They already have so many other things to do. And admission, you ask tons of questions to do the admission navigator, and then you're giving them another sheet of paper to do checklist. So how challenging that was for you to give a paper to fill, another paper to fill?
Yes. Out of the 33 patients, I always see that maybe 30% with this type of challenges. And so I will come for the round, then I will say that, oh, his mental status is low. He is cognitively impaired, so they cannot do that. He is too sick. So that was one of the drawbacks. I couldn't do the completion percentage that much. But then we said that the family, if available, they can do for him. And if there is one-to-one, these questions are covered because they are always watched. But when I see them patients who are moving, they are the one, more higher fall risk, and they need to do it. They know they will not agree that they are having this problem. So when they do that, it is helpful for them. So real sick patients, either maybe they one-to-one or the family were doing it, or the nurse were not even bothering to give it. But this is
what kind of unit was it? Med-surg, neuro?
Med-surg, medical, comprehensive medical unit.
Okay. Thank you, sir.
Thank you so much. Thank you, everybody.
Buying from the staff, that was the first thing. So found out champions who is interested in this project, and found out what are the barriers for that one. So that was the first part. Second part was select, tailor and implement interventions did the pre-survey and developed an educational program, and which was inbuilt in the LMS system, so where the employees can access. And there was posters in the ICU, Q shift reminders for the completion of ABCD of care bundle, the night shift, evening shift, and also the morning shift huddle as well. And SAT and SPT has been added to the rounding tool, so during the morning rounds, there was no chance to avoid that piece from the rounding tool. And daily audits has been done for the patients, and night shift rounds, we included the night shift respiratory therapists in the night shift huddle, because we have to have a plan between the RNs, RTs, and physicians, which patients are ready to be extubated in the morning. And also, of course, unit champions. And evaluated the outcome with the post-survey, and post-survey showed increased nurses' knowledge.
We can relate to. Favorite music, sit down, talk to them. Support group is another thing that you can help. And then early referral to patients. Especially patients who undergo bypass surgery and all, they go through lifelong stress. They have lifelong cardiac anxiety because they don't know when they're going to heart attack, when is there going to be the last day of their life, when is some acute event going to happen. Those kind of patients definitely need psychological referral, psychiatry referral, and managed health.
We can do that.
It's very tough.
So we have our appreciation. And then send it to
Grace Samuel, DNP RN, family nurse practitioner, board certified. She is a seasoned professional with over 13 years of experience as a family nurse practitioner and earned her doctorate DNP from Grand Canyon University. Dr. Samuel is an active member of American Association of Indian Nurses of New Jersey. Go New Jersey, chapter 2. Let's welcome.
How it leads to sustained improvements. Studying the cost effectiveness of the intervention would support healthcare decision makers. Next is the voice and text message can benefit a wider audience, and they will reinforce education and support to impact self-efficacy and self-care. Interactive messages allow patients to be engaged, which leads to more significant improvement in glycemic control. It would be great to see how this project impact any other ethnic groups in the population, studying a particular ethnic group. Sustainability recommendations, the intervention should become standard practice so all patients with diabetes can benefit. Ongoing education and training will equip providers to engage patients with technology and improve communications. Regular audits of patient records will ensure staff compliance with the change. Here are my references. Any questions?
Good job.
Time for questions. Thank you so much. It was a very nice presentation and topic. I have a question. You have population when you selected her Asian, Hispanic, Black. Did you try to look like difference between these populations? What was the outcome?
The Asians mainly a few Chinese people and mostly all Indians.
The certificate of appreciation for Dr. Grace Samuel in recognition of your exceptional podium presentation on innovative diabetes care, a nursing-led text messaging program to enhance glycemic outcomes at the NINA Clinical Excellence and Leadership Conference, SALT 2025, held in Pennsylvania on September 19 to 20, 2025. Congratulations.
which is because each system has its own set of orders and formulas. He used Cerner. That is also an
We're
old
going to
one.
be going towards Cerner. I don't know
No,
when.
he always thinks Cerner is very old. We have to
This
go
is
forward.
computerized patient record system.
But they are under the
CPRS.
gabapentin and the hydroxyzine, which is actually scheduled. So
The gabapentin is scheduled, hydroxyzine is as needed. Because there are certain things with hydroxyzine we should know with the pharmacology because it can prolong the QT interval and it has certain interactions with other medications. So we just have to be mindful of that.
How's the outpatient follow-ups?
So that is a very good question. So that was supposed to be the part, like the subsequent part of this, of the PDSA cycle. We just did not have many staff members to help with the outpatient follow-up. But at the Veterans Center, we do have a robust outpatient community, like a team, and they do follow up these veterans. So whenever they get discharged, they get a post-discharge phone call. Just checking on them, how are you all doing, you know, if you have received your
That's what the business entrepreneurship. That means purely it's a difference between social entrepreneurship. Social entrepreneurship, you're looking at the society problems, you have a burden about normal problems going into society, and you're converting that into business idea because you're nursing knowledge, right? And you're going into business entrepreneurship, random things, has got nothing to do with healthcare, but you personally have a passion, right? But you are a leader, and you already, as a nurse, you already always do entrepreneur. That's the right word, right? Entrepreneurship, correct? So you use that into whatever your passion has. I want to wake you up, so they're not dancing. So.
Dancing? I'm ready to capture.
I know. Format is not just the monotonous, the traditional lecture format. It is panel discussions, and also we had demonstrations. So different kinds of formats which we use to uplift the frontline staff, and also their skills development. And also we had a presentation on burn management. So they've demonstrated how to perform in a sterile technique and everything. So it is more interesting and different ways to uplift our frontline staff. And that's what I told you, that collaborative planning. I plan work with educators, frontline staff, and content experts to develop the content. And they present during the nursing grand rounds. So those are all from the latest evidence-based practices. That's within 5 years of evidences.
This study show that the structured training program can work quickly and effectively, and it can bridge skill gap among novice ICU nurses especially, and can improve patient safety and broad implication for practice and policy. Thank you.
This is a time for question, Q&A session, so if you have any questions, this is your time.
I have a question. What are some of the unexpected challenges that you encountered during data collection process, or maybe training, or throughout the study?
Thank you for a great question. Actually, it was one of the most challenging barrier was in collecting the data. When we went to collect the data, you know, it was one ICU, and the number of new nurses was limited. So we try to expand the time frame. It takes maybe 2 years to get the 56 new nurses. Yeah.
Thank you, and again, good luck with your studies.
Thank you so much.
there were some town hall meetings, and we also had some discussions during NINA meetings to disseminate this information. And we were one of the A&E collaborators for this study, so that's how we went about. So the social media that we had actually used to disseminate this information was actually Facebook, LinkedIn, Instagram, and Twitter, but we only looked at actually Facebook and LinkedIn in this particular study. And so we also did our qualitative study using RedCap, and then and we used QSR in vivo version 14 to analyze the data that we received among the 12 participants. So I will hand over the next part of the presentation to Dr. Ann Lucas. Thank you very much for giving me this opportunity to present, and I want to thank NINA because this happened during my presidency, and then followed by Suja, and now we have the third president, and we are still doing the study, right? So it takes time.
And so yeah, as Lydia said, for the qualitative aspect, we use RedCap. Some of you may be familiar with RedCap in institutions, right? We gather the data, and then we analyze what QSR and Go, version 14. So we saw with Facebook, there was a marginally significant more reach or reaction than LinkedIn. Marginal, okay? We are 0.08, so it's not 0.05 or less than that. So it's the marginal difference. And then LinkedIn generated more impressions. That was significant than Facebook. And we have numbers over here also in terms of NLM and NSM. Okay? If this makes sense to you. Here, significant for impressions, and for reach and reactions, you can say marginally.
All right, I'll turn over to, thank you Anne and Lydia, and I want to say thank you to Lydia for bringing this project to NINA and getting the grant and making this effort fruitful. So thank you for that. You can hear me.
Yes.
So, like Anne discussed, descriptive phenomenology. We wanted to learn the lived experience of the nurses. And then, of course, when we say qualitative study, we wanted to know their perspectives, how they, like, we wanted to know how they lived through that situation and time. So whenever we do a qualitative study, we have to make sure there is rigor and trustworthiness. And we had 12 people, like in qualitative study, we don't need 100 people because we need a small sample. And then what all things we follow. So to maintain rigor and trustworthiness in qualitative study, we followed Lincoln and Guba's trustworthiness criteria. So we had an excellent group of researchers. I know 3 of us were there, but we had 2 other people, a statistician, he's a professor of psychology, and we had a data analyst there. So, and then we had 1 more person, so 5 investigators were there, and we made sure there was consensus among the coding or consensus among the themes we developed. And there were peer checking. We made sure that this study followed Institutional Review Board guidelines. We made sure we had this ethical approval in place, and we did everything exactly as per the ethical guidelines. And there was credibility. We made sure we followed the guidelines. And these findings, like if we do this study in another setting, that is doable. Like there is problem.
Thank you, Dr. Misha Matthews and Dr. Lydia Malgarkar for the great work, and wish you all the best for the completion of the research.
Thank you.
Committee and chair members for allowing me the opportunity to present, and for all of you who are attending and listening to me speak today as well. And before I start, actually, I wanted to ask if you are familiar with the term global surgery and you know what it encompasses. Collaboration collaboration between sites and give the administration more reason to make this a more formalized opportunity as well. And in conclusion, that despite a high level of interest, nursing professionals are not really commonly engaged in the global surgery project, despite the high interest. And although our study is limited by several factors, such as just a lower sample size, our study being held in a tertiary and research-heavy institution where global health.
Does that mean you can use the privileges? Like if you have to work in the United States, you have to earn some privileges here to work. So when you have the global surgery platform, you can go and work anywhere else without getting a specific legality attached to that country. Is that what it means?
I'm not exactly sure. From my experience working with some medical attendings, they had to, when they would go abroad for a clinical trip, for example, in practice, actually practice medicine, they would need to get an approval from the local government and get their license transferred over. But when it comes to things like research, often people collaborate with a host institution in a different country, and through that means that they can get some of the legal approvals that are necessary, but it often just depends on the project itself.
Thank you so much. Thank you so much. This is the time if you are moving into different rooms or coming into this room, we're going to get ready for the final and the fifth presentation of this particular. Of diagnosis with no hospitalization. So that was also my focus of during my interview. That was my focus. Why that happens? Why there is. So we'll answer that at the end. So anyway, the results. So I was able to extrapolate around 7 tenets out of the interview. And out of the analysis and synthesis, I was able to extrapolate 7 tenets and 22 sub-themes. 7 themes and 22 sub-themes. So in order to go to the 22 sub-themes, it's very impossible for this 15 minutes, but I will highlight the points. Okay, so the time is the one main factor that emerges as the most important factor, time.